Hi, welcome to this virtual tumor board. I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine and the clinical director at the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. We have a wonderful panel today, a multidisciplinary approach discussing 9 cases. We'll start with introductions. And Dr. Force, if you want to start.
Sure. I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of General Thoracic Surgery at Emory University Hospital in Atlanta.
Thanks, Dr. Force. Moving around the Zoom room, Dr. Kamich.
Hi, I'm Dr. Ross Kamich. I'm the Director of Thoracic Oncology at the University of Colorado Cancer Center. I'm a medical oncologist where I hold the Joyce Seth Chair in Lung Cancer Research.
Great. Next, Dr. Higgins.
Hi, I'm Dr. Kristen Higgins. I'm a radiation oncologist. I specialize in thoracic malignancies at Winship Cancer Institute of Emory University.
Great. And rounding us out, the radiologist, Dr. Keys.
Hi, my name is Dr. Darren Keys. I'm a diagnostic and interventional radiologist for Piedmont South Imaging, covering Piedmont Fayette Hospital and Piedmont Noonan Hospital, south of Atlanta.
Great. So let's move on. Dr. Higgins.
All right, so this gentleman is a Caucasian male, 73, with a new cough and unexplained fevers, no other major comorbidities. He had a good performance status. Next slide. He did just have some mild osteoarthritis, right hip replacement, and erectile dysfunction. He had a 15-packer history of tobacco use, but quit 15 years ago. He's married and is working and had a mother with colon cancer. Next slide. So his imaging showed a chest CT with a left upper lobe mass, as well as bilateral paratracheal lymphadenopathy, and Dr. Keys will review that in a moment. He did undergo a EBUS of his mediastinum. 4R and level 7 lymph nodes were positive for adeno, TTF1 positive. And I'll give it to Dr. Keys.
So here we have 4 axial PET CT images showing multiple abnormal lymph nodes within the mediastinum that show increased FDG uptake. And there's also a large FDG avid mass in the left upper lobe with some surrounding areas of parenchymal infiltration. These findings are all consistent with a lung cancer with mediastinal lymph node metastases.
Okay.
So the patient, again, was found to have multi-stage N2 disease. It was biopsy proven. It was decided that he would be best served with definitive chemoradiation and no resection. He was treated to 60 gray to the areas of PET positive disease, including the left upper lobe primary and the mediastinum. You can see just this coronal image showing his radiation isodose lines in the thorax. And this is his dose volume histogram that shows that all of his radiation doses to his normal organs were within tolerance. And he was planned after his definitive thoracic radiation to undergo immunotherapy.
Great. Just can we just pause there just real quick, turning it over to Dr. Kamich briefly. Your systemic chemotherapy of choice for patients who are getting definitive radiation, and then once again, a brief overview. I know you've presented it before, but a brief overview of the rationale of delivering durvalumab in an unresectable lung cancer patient.
So there are pretty much 3 regimes that you can consider for giving in combination with radiation. So weekly carboplatin and paclitaxel, which is usually considered the best tolerated, certainly the one you would give for the sort of frailer candidates. There's some concern there that the systemic doses are relatively low. Cisplatin and etoposide in an exaggerated spread out regime, which is usually like a 5-day regime, actually technically a 6-day regime given every 28 days. That's certainly the one that I would prefer for most people. And then the only other regime is full dose carboplatin and pemetrexed, which wasn't shown to be superior. And I only really reserve that if it's a patient that I know has one of the gene rearrangement diseases, because ALK, RET, and ROS are super sensitive to pemetrexed. So that's a little niche indication. So in a fit patient, I would have used platinum etoposide, but this may have been a less fit patient.
Great. And just briefly, again, a summary of the Pacific data and the reasoning for using durvalumab.
Oh, yeah, thank you. So durvalumab is a PD-L1 inhibitor given intravenously every 2 weeks after completion of definitive chemoradiotherapy. And what you're trying to do is jazz up the immune system to go after any residual disease and increase the cure rate. And that's what the Pacific study showed. It improved the time for the relapse, so that fewer people relapsed, but also people lived longer. The overall survival was positive, and I think that convinced a lot of people this was the way to go.
Great. And just one more question about durvalumab, and then we'll get back to Dr. Higgins and some of the findings prior to durvalumab. The timing of durvalumab and when you give it after radiation. How long do you wait? And is there a rhyme or reason to the timing?
Well, it's a little fuzzy because the people who get it further away from the end of their chemoradiotherapy do a little worse, but you don't know if that's because of the timing of the durvalumab or just that they needed more time to recover because they were, less fit people or had a tougher time with the chemoradiotherapy. So it's a little confounded. I think in general, in an ideal world, you would tend to give it relatively soon.
Okay. One last question, a bit of a curveball. You mentioned some of these genotypes, ALK, ROS, RET, some of these mutations, the genomic underpinning of the tumor, which we know how to treat for advanced stage disease. If these patients have stage 4 or advanced, we do have data for all of these targeted therapies. Do you ever consider targeted therapies for stage 3B, not 4, in the setting, in a case like this? Would you ever consider delivering targeted therapies if you knew the genotype or the genetic underpinnings and there was an approved targeted therapy, at least in the advanced stage setting?
So people have talked about, could you use it beforehand? And the only advantage of that is if you could shrink it down such that Dr. Higgins' radiotherapy field would be less damaging to the normal tissues. Of course, it depends on how it shrinks down. I do have a slight worry, particularly if they're not going for radiotherapy, but they're going to Dr. Force for surgery, that by putting somebody on a really active targeted therapy, you could understage them. So Dr. Force takes out the nodes and says they're negative, even that's just because they've had a dramatic response, and then we don't have the discussion about adjuvant chemo. The whole adjuvant, so after these definitive treatments, adjuvant use of targeted therapy, I think is highly controversial. I'm certainly in the camp that this is much more akin to a suppressive therapy rather than a curative therapy. And I don't have an issue with going on it. I have a big issue with stopping it after a defined sense of time because I don't think it changes the cure rate.
Got it. And Dr. Force, just to bring you in, although you're probably off the hook for this stage 3B lung cancer, but Dr. Kamich mentioned that surgery is sometimes used at least for 3A. Is there ever a role for surgery for stage 3B?
Not really. When those studies were done, it really, and there was one landmark one, I think, from MD Anderson, and it was stopped early because there really was no surgical benefit. I mean, we never say never. So we operate on stage 4 cancer, lung cancer sometimes. So you never say never, but as a general rule, we tend not to operate on 3B because it doesn't offer a survival advantage.
Okay. So Dr. Higgins, let's move on to the case.
So this patient completed chemoradiation and had good toleration of the treatment, and he underwent his first CT chest about 2 weeks after his radiation and chemotherapy was complete. And I'll leave it to Dr. Keys here to explain these radiographic findings.
So here we have 2 axial CT images of the chest taken at the same level. The one on the left is in lung windows and the one on the right is in soft tissue windows. You can see that there's a spiculated mass in the upper lobe of the left lung. It has decreased in size compared to the images we looked at previously. However, there is some mediastinal lymphadenopathy as well in the pretracheal or the paratracheal space that appears more prominent than seen on the prior exam. There's also a periaortic lymph node. So, these findings show a somewhat mixed response to therapy.
And so, Dr. Higgins, do we see this type of, can this be from radiation, this discrepancy between the mass and the nodes? And is this worrisome for you?
So it's interesting. Before the Pacific data, we would not do a CT scan until at least 8 weeks, sometimes 12 weeks post chemoradiation. And the purpose of that was to let the post-radiation inflammation start to go down, because if you do the scan really early, you can get just these amorphous looking lymph nodes that are still inflamed from treatment, and you can't really assess the response to therapy. But now with immunotherapy and the Pacific data, we scan sort of right after we finish therapy to make sure there's no evidence of progression that would contraindicate durvalumab. So it sort of changes things, and now we're seeing things that we didn't used to see because we didn't check at this time point. So we actually reviewed this case in our own tumor board, and I feel strongly that in this situation, the purpose of the scan is to assess for distant progression. We know that the primary tumor and the lymph nodes are still responding, and this is not sort of the scan that we assess definitive response within the primary site or the lymph nodes. We're just making sure there's no distant progression so we can start immunotherapy.
So immunotherapy was started in this case,
Mm-hmm.
and
Yeah.
and the imaging findings were just followed over time.
Yes.
Okay.
We're getting CT scans every 3 months.
Okay. Just quickly, Dr. Forster, Dr. Kamich, just the timing, or maybe Dr. Kamich, given that you see more of these, the timing of the imaging that you get post. We talked about the timing of the durva, but when you want to get a scan post concurrent chemoradiation.
Well, so in the real world, you probably don't. I mean, that was built into the Pacific trial. As you can see, you can cause some degree of confusion and anxiety as a relation to it. What you're really looking for, as Dr. Higgins says, is, did the other shoe drop and suddenly is there a liver metastasis or something, and you'd be very much changing your plan. I guess maybe you do it sort of 6 weeks after the chemoradiotherapy is probably what I do it outside of the clinical trial setting.
Okay, very good.